Good evening, everybody. Thank you all for participating at this webinar on cow's milk protein allergy. First of all, I would like to thank Fonterra for organizing this less discussed topic, but which I feel is a very, very valuable topic, especially in your practice. Right. Okay, so we'll start the presentation. Cow's milk protein allergy, which is also known as cow's milk allergy, has a varying presentation or prevalence. In different studies, the prevalence can change from 0.25 to 4.9%, and it is higher in children than in adults. It's more in referred population. The referred population are populations of people who are referred to allergy clinics. Please tell if you have a question at the end and type it in the comment box, please. So we will take up question by question. You can type in the comment box. Now, cow's milk protein allergy is different from lactose intolerance. This often confused thing. Cow's milk protein allergy is allergy to proteins in the cow's milk. The common proteins are caseins and whey, and it is different from lactose intolerance. Lactose is a disaccharide which is made up of glucose and galactose. But if the cow's milk protein allergy exists for a longer period in a child, it can lead to an enteropathy, and this enteropathy can cause secondary lactose. You can have an instance where there's cow's milk protein allergy which has led to lactose intolerance. So there's an overlap sometimes, but cow's milk protein allergy is different from lactose intolerance. Now, when it comes to cow's milk protein allergy, there are two different mechanisms by which cow's milk protein allergy can happen. You can have IgE-mediated cow's milk protein allergy as well as non-IgE-mediated cow's milk protein allergy. I will not go into details of immunology, but it is important for you to diagnose that you are aware of these two arms of cow's milk protein allergy. Now, when the milk is ingested, it is digested in the gastrointestinal tract. The protein digestion happens, and there's some kind of antigen processing in the mucosa of the gut, and these antigens enter the bloodstream. And they are taken over by the antigen processing cell, which is macrophage normally, and these macrophages in turn stimulate the T cells of your immune system. Now, these T cells can directly release chemicals like tumor necrosis factor or interleukin 5, and this tumor necrosis factor or interleukin 5 can stimulate and trigger an allergic reaction, that is non-IgE mediated allergic reaction. Now, these T cells in turn can stimulate B cells, and these B cells release IgE, and this IgE is bound to mast cells in the circulatory system and also in various tissues. And when this IgE is bound to the proteins, milk proteins, they degranulate and release histamine. So you get the IgE-related cow's milk protein allergy due to histamine release from the mast cells. So you can understand there are two arms in the cow's milk protein allergy. Why it is important is that when it comes to the presentation, generally the IgE-mediated cow's milk protein allergy and non-IgE-mediated cow's milk protein allergy have different symptoms. Now, generally, IgE mediated, I would like to use the word generally, IgE mediated cow's milk protein allergy would cause immediate symptoms or symptoms which happen less than 2 hours of taking cow's milk. So they are pruritus, acute urticaria, angioedema, nausea and vomiting can happen due to cow's milk protein allergy, and also lower and upper respiratory tract symptoms such as rhinitis and wheezing, and also the most deadliest complication of IgE-mediated cow's milk protein allergy is anaphylaxis. So there are people who actually develop anaphylaxis due to cow's milk protein allergy. And then you have in the non-IgE arm, which can cause delayed onset type of symptoms. You can have eczema, gastrointestinal reflux disease, and blood and mucus in stools, colic, constipation, and low respiratory tract symptoms also. But also, sometimes you can have mixed pattern of IgE-mediated cow's milk allergy symptoms as well as non-IgE-mediated cow's milk allergy symptoms. So you can see lactose intolerance is a completely different. It's a completely different type of disorder. It's not related to cow's milk protein allergy. Now I will come into the details of reactions because it's very important for you to identify the cow's milk allergy, protein allergy symptoms. So immediate reactions, which as I told you, happens less than 2 hours of ingestion. It's IgE-mediated usually. Urticaria are hives, you can see in this picture. Angioedema is swelling. Swelling can happen only in one part of the body, maybe the face, or even you can get generalized edema. And you can also have acute flare of atopic eczema. So a child or a person can have eczema, and this eczema can flare up due to IgE-mediated reaction, which would happen during 2 hours of ingestion of milk. And then you can have gastrointestinal reactions such as vomiting and diarrhea as well as colic. Now, the deadliest immediate reaction, which is IgE-mediated, is anaphylaxis. Anaphylaxis, you are aware, is a severe manifestation, which is a life-threatening one, can happen within minutes to 2 hours after ingestion of cow's milk and sudden onset. So usually they begin by having urticaria, angioedema, which can in turn lead to vomiting, dyspnea, bronchospasm, and hypotension, hypotonia, syncope, and ultimately shock. So anaphylaxis is the most dangerous complication of cow's milk allergy. Now, when it comes to immediate reactions, there's a kind of a syndrome where you have non-IgE-mediated cow's milk protein allergy causing enterocolitis type of a syndrome. So there what happens is the child takes milk, and this milk produces a delayed type of reaction with after a few hours of taking milk, he or she can develop a vomiting and diarrhea. And this can even mimic sepsis. So child presents with vomiting and diarrhea due to delayed non-IgE-mediated cow's milk induced enterocolitis syndrome. So other immediate reactions are respiratory symptoms, which can be wheezing or allergic rhinitis, as I told earlier. But these symptoms usually do not happen as isolated. For example, rhinitis or wheezing can come with urticaria, or it can come with angioedema. So as an isolated symptom, respiratory symptoms are rare. Now, what are the delayed reactions? The commonest delayed reaction is milk-induced enterocolitis, or it is also called enteropathy or proctocolitis. And in this, usually an infant presents with rectal bleeding. So this is mostly happening in children, young infants who are exclusively breastfed. So how it happens is that the mother takes cow's milk, and there's a non-IgE-mediated reaction in the child due to the milk which is secreted, cow's milk secreted in mother's breast milk, and this can cause usually bloody diarrhea or pure blood in stools. It can cause diarrhea as well as steatorrhea, which is bulky stools. And if it prolongs for a longer time, it can cause failure to thrive and also can lead to lactose intolerance, secondary lactose intolerance, and also acidic stools can cause perianal excoriation. And it can also happen not only due to cow's milk protein allergy. It's important to be aware of this. Can be caused due to protein, soya protein allergy, fish or chicken, or any other many other allergies can cause this bloody stools. Actually. So you can have a child who is absolutely normal, who is an infant, presenting to you with blood in stools. So it is a very common presentation to have this type of a delayed reaction, which is a non-IgE mediated reaction due to cow's milk protein allergy. And then you have these eosinophilic gastrointestinal disorders, which in children usually present like a gastroesophageal reflux. They present with vomiting, distension of the abdomen. In adults too, also this can happen like dysphagia, difficulty in swallowing, and food infection. And they can be relapsing. There can be relapsing type of symptom due to this. Now, in eosinophilic gastrointestinal disorders or syndrome, you don't have eosinophilia in blood, but the eosinophilia is actually in the gut mucosa. So that's why it's called eosinophilic gastrointestinal disorder. So the eosinophil count can be normal in this condition, and the children can present with failure to thrive, iron deficiency anemia due to prolonged occult blood, or hypoalbuminemia also as recurrent abdominal pain. Now, the other delayed reactions are atopic dermatitis or eczema. Eczema is present in about 10 to 15% of young children, and 1/3 of them can have moderate to severe atopic dermatitis flaring up or caused by cow's milk allergy. And there is a rare syndrome, a rare disease called Hainer syndrome, which is a male-induced chronic pulmonary disease, which is a kind of a pulmonary infiltrate which is causing chronic cough, but it is a rare condition which is due to delayed reaction due to cow's milk protein allergy. There's a common belief among some members of the public, generally we also hear this, that cow's milk can cause phlegm or semer. But the studies which have been done on this have not proven that there is such a relationship between chronic phlegm or chronic production of mucus and cow's milk. Now I have described about the symptoms of cow's milk protein allergy. Now, how do you make a diagnosis? Now, as I told you, to diagnose, you have to know the presentation. So it's important to know about the comprehensive history, including the family history for atopy, and physical examination. As I told you, physical examination includes what I have described already. And you can understand there's no single one symptom which is typical of cow's milk allergy. So it can present with varying types of signs and symptoms. And it is important for you to understand the timing and pattern of symptoms. It's easy in IgE-mediated cow's milk protein allergy because you will have the reaction and signs and symptoms within few hours, in 2 hours of taking cow's milk. But when it comes to non-IgE mediated, it is very difficult because it can happen later on. So it happens usually first week after introduction of cow's milk protein to children, but it can also appear at eating age. Now, this is also very important fact to remember. A person who has never been allergic to cow's milk suddenly can become allergic to cow's milk. Nobody knows how it happens, but it happens, and I've seen patients who are presenting like this even at an older age. Now, I will not go through the entire list of presenting system of symptoms. I have described them in detail earlier. So there can be varying presentations such as vomiting, diarrhea, constipation, blood in stools, iron deficiency anemia, cough, wheezing, dermatitis, and also even the severe form of anaphylaxis, laryngeal edema. There are so many symptoms where a person can present to you with which a person can present to you having cow's milk protein allergy. Now, how do you test for cow's milk protein allergy? Now, there are few tests that you can do to confirm cow's milk protein allergy. One is skin prick testing. It's done to diagnose IgE-mediated cow's milk allergy. Skin prick testing, what you do is you place a drop of milk or commercial reagent which has the similar activities of milk, and 20 minutes later, you see that after a prick or scratch, you look at the reaction. And if the reaction is more than 3 millimeters, you can diagnose cow's milk protein allergy in such a person. But this has to be done with a control of histamine. Histamine and saline is added as control to this test to confirm that the test is accurate. So in all places it cannot be done, but an allergist can do this test to confirm that there's IgE-mediated cow's milk protein allergy. Now the test you can do commonly is the IgE-mediated. To diagnose IgE-mediated is the specific IgE level against cow's milk protein, such as casein, galactose. So you can request for cow's milk protein specific IgE. The cost is around 3,000 rupees. I'll show you a report like this. Now, this is like a panel. It's quite expensive. It's, I think, about 12,000 rupees. But you can ask for milk alone. So you can ask for specific IgE level for cow's milk. And they would do the test for only cow's milk. And how you read this, it's important for you to look at the body at the end of the report to diagnose this, because there are certain levels which are given. So anything above 3.5 only is a significant antibody titer and clinical symptoms usually present. So you can have a false negative result if a person is off cow's milk for a very long period. Then the IgE level would become negative or less than normal. So also you can come at a wrong positive diagnosis if you don't look at the legend of the report, because the legend of the report and arrival is important. Just because it's about 0.35%, you don't diagnose cow's milk allergy. You have to correlate the symptoms with the level of the titer, and then with that only you can arrive at the diagnosis. So it's important for you to diagnose. You have to identify the level of the IgE in this type of report. So cost is around 3,000 rupees. Many hospitals, especially private hospitals, do. And now to diagnose how non-IgE mediated cow's milk protein allergy, it's little more complicated. History is more important than anything else for you to diagnose non-IgE mediated cow's milk protein allergy. But you can do atopic patch test. Now, patch testing is done like this. Now, this is how I do it. Actually, this patient, in this patient, we have not done it for cow's milk protein allergy. This has been done to diagnose hair dye allergy. So what you do there is you place a patch with cow's milk on the skin, or a reagent which is similar to cow's milk on the skin, and 3 days later it is read and see whether there's a reaction. To diagnose cow's milk protein allergy. Now, other more important test is elimination and challenge test. Now, that is supposed to be the definitive procedure for diagnosing cow's milk allergy. So this is a test that you can do. So what you do here is that you suspect that the person is, or a child is having cow's milk protein allergy, and you put the child or a person on exclusive elimination of cow's milk from the diet. So this would include not only fresh milk or powdered milk, but yogurt, cheese, butter, or biscuits which contain cow's milk. So you put the patient on 3 to 4 weeks of elimination diet. Now, when it comes to, as I told you, non-IgE mediated cow's milk protein allergy in an infant, you have to request the mother breastfeeding. happen? The child is anyway breastfed. He does not take any other food. So even if the infant is taking food, the child has to be taken off all kind of milk-containing food, including certain kind of cereals, which actually contain milk. And so you have to take all kind of food out of the child as well as the mother. So you put the child or the person on 2 to 4 weeks of elimination diet, and if the symptoms substantially improve and disappear, and then you introduce cow's milk again, if the symptoms appear, then you can come to a conclusion of cow's milk protein. Now, again, it is very easy to diagnose IgE-mediated symptoms such as urticaria or angioedema because they happen within few hours of reintroduction of cow's milk. But when it comes to delayed reaction or non-IgE mediated, it's little more difficult because you have to put the child on the cow's milk for a longer period of time again after reintroduction for about 7 to 14 days, 1 to 2 weeks, to see whether these reactions happen. So it's little more difficult when it comes to the diagnosis of non-IgE mediated cow's milk allergy. Now, the other thing is open challenge. Open challenge is done in patients in whom already the patient is on cow's milk exclusion diet. The patient is not on cow's milk and do the challenge, but this is quite a dangerous thing to do. So it has to be done by a trained person. So you introduce formula and see whether there's a reaction. But if the previous reaction was an anaphylaxis, you should never do it. And also, even if the previous reaction was mild, you can never predict the reaction which will happen when you do the open challenge. So therefore, the open challenge has to be done under controlled circumstances, ideally in a hospital circumstance. So what the common thing you can do is the elimination and challenge testing. You take the patient off cow's milk for 4 weeks and then reintroduce it after that and see whether the symptoms. Now, I will come to, now we have discussed about the symptoms, we have discussed how to diagnose cow's milk protein allergy. Now we will come to modalities of treating cow's milk protein allergy. Now the easiest or difficult, but the commonly done thing is avoidance of cow's milk protein allergy, but it's almost impossible. But what has to be done there is that you have to take the child or the person off all kinds of cow's milk and cow's milk protein-based products, yogurt, cheese, and butter. And the mothers of breastfed children who are having cow's milk protein allergy, as I told you earlier, should continue breastfeeding but avoid milk-containing food. And also, if you are on a cow's milk exclusion diet, if the patient is on a cow's milk exclusion diet, you have to read the labels of all the things. But they are also impossible in Sri Lanka because most of the time what are added to items, they don't mention in labels. So once the patient is on a cow's milk exclusion diet, then the issue will be nutrition. So you have to discuss with or refer to a dietitian about giving a well-balanced diet with proteins and calcium, which contain which would become deficient if the patient is not taking cow's milk. Second thing is in a patient who is not having severe symptoms of cow's milk protein allergy, then you can go for an incomplete milk avoidance. So that's limited use of milk. And also you can use extensively heated milk. So what will happen when you heat milk is that the proteins in the milk would become denatured to a certain extent. So the outlook of the nature of the protein would change, and denatured proteins are less allergic to people. So you can boil the milk or you can powder. You can use powdered milk because in powdering mechanism, what happens is the milk is heated up to 200 degrees centigrade. So naturally, when it's powdered, the proteins are denatured. And you can also use extensively alternate formulas such as extensively hydrolyzed formula which are actually amino acid based formula, which are not available in Sri Lanka. And also you can use soya formula. And soya formula can be effective up to 85% of infants with cow's milk IgE-mediated cow's milk protein allergy, and 50% with non-IgE-mediated cow's milk protein allergy. So you can understand there is a percentage who would not respond for soya formula, but it is not recommended for infants below 6 months due to a suspicion of estrogen containing in soya protein. Now, rice hybrid formula is not available in Sri Lanka. So these are the alternate formula. So what is not recommended for cow's milk protein allergy, especially cow's milk protein allergy, severe form of cow's milk allergy, you can't use milk substitutes such as yogurt and cheese. You can't use partially hydrolyzed formula. Partially hydrolyzed formula can also throw a severe reaction to people who are having severe symptoms of cow's milk protein allergy. Goat, sheep, and buffalo and horse milk, you usually use goat milk in Sri Lanka, are also not recommended in, especially in severe form of cow's milk allergy. And then you are left with the other options of total avoidance. Now, the other option you can have, what is not commonly used, not commonly advocated in Sri Lanka, is allergen immunotherapy. Allergen immunotherapy is done by introducing a food or drug to a patient in gradually incremental dose over a period of time, and according to a predetermined protocol, after carefully selecting the patients in a safe environment. And when it is done, the patient will be able to, or the child will be able to take milk without any reaction. This can be done for other food items as well as in drug allergy as well. Now, how it is done is that firstly, the level at which a patient would have allergic reaction be done. For example, supposing by taking the history, you decide that the child is having cow's milk protein allergy by taking 10 ml of milk. So what happened in this process is that a dilution after calculation is made up to 10 to the power minus 6. And this 10 to the power minus 6 dose of cow's milk is given through 18 concentrations, gradually increasing up to 10 ml of milk. And finally reaching the desired dose, as I told you. So how it should be introduced has to be decided by an allergist, and it is done sometimes in the hospital, which is called rush immunotherapy over 24 hours. So these 18 bottles are given over 24 hours. And this type of rush immunotherapy is done in patients in hospitals, because you can't keep a patient in a hospital for a long period of time. People who are having severe kind of allergic reactions, they are admitted to hospital. We get ready for the severe form of allergy, which is anaphylaxis, and under continuous monitoring, rush immunotherapy will be done. But in patients who are having less severe form of cow's milk allergy, you can do slow immunotherapy over 6 days over 6 days at home. So there, what happens is the patient is given the 18 bottles, which contain incremental doses. The bottles are numbered, and 3 times a day they take these bottles, and within 6 days they become desensitized. So they can be So randomized control trials have reported that about 35 children become fully tolerant to cow's milk protein after doing this immunotherapy, but 15 to 20% may not complete the procedure due to severe adverse reactions. But these are actually predictable reactions, so they are not done. This type of patients, in this type of patient, immunotherapy is not done at home. And no fatal events have been documented because probably it's done under controlled settings. And there are many protocols. I describe you the protocol adopted at Lung Hospital, and it has to be done by people who are trained in this procedure. Now, what happens during immunotherapy is that it's a complex thing, not very well understood yet. You have two types of T cells. You have T helper cell 1 and T helper cell 2 cells. Th2 cells are the cells which would actually throw an allergic reaction. And Th1 cells actually is a protective cell. So in this immunotherapy process of immunotherapy, what is believed is that the T helper cell activity is enhanced. Th2 activities is suppressed. So therefore, the patient becomes tolerant to cow's milk. So this can be done, as I told you, to many things. We have done for milk, chicken, such as so many things, and coconut milk, tomatoes. In drugs also, this procedure can be adopted. So these are different protocols adopted in different hospitals and different people who are doing this desensitization process. So now we have done about the mechanisms or modalities how to manage a patient with cow's milk protein allergy. But if you have a patient who is on total exclusion diet, total exclusion of milk, it is important to enhance and time to time get down the patient and tell about adherence to diet, and you have to monitor the growth, and also you have to control coexisting disorders. Now, patient may have wheezing or rhinitis; those things have to be they have to be addressed, and you have to make them aware of reading labels, and they have to be prepared for emergencies as well. Now, adrenaline in patients who are having severe reactions to cow's milk protein allergy is an important, most important drug. That unfortunately it is still available only in one form of EpiPen. It's very expensive and it has a very short expiry, and is time to time not available in this country. So what I do is I give a sample of adrenaline, show them how to use it in case of emergency, but I advise them to take it to a practitioner in the event of the closest practitioner is available in the event of anaphylaxis. And also you can do periodic rechelling. Now these patients are on total exclusion, but exclusion need not be for life. You can do the rechelling, a mild allergy, 6 to 12 months, and see whether the patient has become tolerant to cow's milk. I will show you how they become the percentage of becoming tolerant to cow's milk protein allergy. If it is an IgE-mediated cow's milk protein allergy, you have done the earlier milk-specific IgE level, and you can repeat it and see whether the level has come down. So by this monitoring period, also you can have idea whether the cow's milk protein allergy in this particular patient is reducing or not. So you can see at the beginning of milk exclusion diet, you do a specific IgE test and you have that level. And 6 months later, you repeat it and see the level, and then you decide whether the patient is becoming tolerant to cow's milk protein. But also, this is not a very reliable test because merely due to the fact that the patient is on an exclusion diet, the IgE level can go down. So as I told you earlier, they should be maintained if it's the only option, elimination diet. Challenges can be repeated. And there has to be, even after reintroduction of cow's milk, you have to monitor the child for a longer period of time because, as I told you, non-IgE mediated symptoms can happen later and it is difficult to diagnose as well. So you have to, if the patient is put on a milk exclusion diet, milk is reintroduced, you don't come to the conclusion that the patient has become tolerant until you monitor the patient for few weeks. So now we come to the rate of resolution. Now, even if you don't do anything for cow's milk allergy, 19% of children who are infants who are having cow's milk protein allergy, 19% will get totally cured of cow's milk allergy by the age of 4 years. 64% will get cured of it at the age of 12 years, and 79% will be cured by cured from cow's milk allergy by the age of 16. So you can see there's a significant resolution, natural resolution of cow's milk protein allergy. So cow's milk protein allergy is not a lifetime disease. It can be a lifetime disease, a lifelong disease in a particular percentage of patients, but not in all. The prognosis of coming out of cow's milk protein allergy would depend on whether it's IgE or non-IgE. Non-IgE mediated cow's milk protein allergy, in non-IgE mediated cow's milk protein allergy, it is common to come out of those symptoms. And they are also less likely to have multiple food allergies. And also, if the titer of specific IgE at the time of diagnosis is low, then there you have a better prognosis. And if the age of onset of cow's milk allergy is infancy, also it has a favorable prognosis. With this, we come to the concluding slide. So this is the most important things to remember. One of the most frequent food allergy, as I told you, the prevalence can be up to 4.7%. That's 1 in 20 of the population. But this prevalence can change from age to age as well. It can present as IgE or non-IgE mediated disease, and the diagnosis primarily on clinical evaluation, that is history and signs and symptoms, is supported by skin prick testing, patch testing, or measurement of specific IgE, and also not to forget elimination and introduction tests, which you can do. And also, it can be treated with avoidance of cow's milk protein products, alternate formula, and oral immunotherapy. And as I told you, the immunotherapy, which is also known as desensitization, is an accepted modality of treatment. And whenever needed, they should be referred to specialists with expertise in allergy. So I think we come to the conclusion of the lecture. Thank you very much for listening to this patient. I can see a large number of past participating in this lecture. That shows the interest people have about this, because it's a less discussed topic among the in the medical fraternity. Thank you very much for listening. I think it's open for question and answer. Yes.
Dear doctors, if you have any questions which you need to get clarified, so you can raise it now. And also we have few questions which are already in our chat box. So the floor is open to you all. If you want to ask any questions, you can ask right now.
Yeah, you can switch on the mic and ask questions.
Hello.
Yes, can hear.
Hello, sir.
Yes, I can hear. Yes, yes.
Yeah, sir. What is the? Yeah, I am Dr. Krishan Vedanayagam from Badula Provincial General Hospital. Hello.
I can hear. I can hear. I can hear.
Yeah. So, what is the safest age to introduce a child with this cow's milk? And if not, what will the later process we can proceed?
It's like this. So there's no consensus about introducing cow's milk. Definitely, I can tell you, unaltered or unchanged cow's milk cannot be introduced under the age of 1 year. So then you have the formula. Actually, exclusive breastfeeding is the best for children. So exclusive breastfeeding has to be advocated as doctors by us. Even that exclusive breastfeeding is not possible. Introduction of cow's milk in a formula type of a thing can be done even from the neonatal age. But unaltered cow's milk has to be introduced immediately after the age of 1 month.
a series of factors that are linked with the development.
Yeah, any questions?
Whatever point is, I think, looking to now.
Thank you very much, sir. As there are very few other questions also raised, I'll just post these questions to sir. So just one question from, I think it's Dr. Lahiru. He has mentioned during your lecture, you mentioned that eating milk will reduce the allergy level. Does that mean full cream milk is less allergenic to fresh milk?
Now, full cream milk powder
Is less allergenic to
it's like now. Yeah, to answer a question, first of all, we have to decide whether a child is having cow's protein allergy or not. Of having fresh milk or the
full cream milk powder
or milk powder, the question of milk having cow's milk, fresh cow's milk and full cream milk powder does not arise. So if there is no cow's milk allergy, then they can either have fresh milk or full cream milk. But when it comes to a child who is having cow's milk protein allergy, they can do two things. One thing that you can take fresh milk, boil it well and drink it. So if you want to have it, you can boil it and take it. And other option is that if you want to drink full cream milk, then you can do that as well. So you can't, there's nothing called like this or that. Both you can take, even fresh milk you can take after boiling.
Thank you, sir. And Dr. Veeratunga has shared a question. Time to time, we have seen several doctors are claiming that consuming powdered milk creates a potential health risk to the consumers. But is there any scientific evidence to prove such claims?
Yeah. Now, actually, I am doing this lecture only on allergy. So I can't tell about the nutritional value or the contents of milk. I'm not qualified to do that basically. It's up to the nutritionist and milk powder experts or milk, whoever, it's up to them. It's not up to me. But I can tell you, I told you earlier as well, when it comes to the allergy, I'm confining my topic to allergy. So there are two ways of looking at this. First of all, whether the child is allergic to cow's milk or not. The child is not allergic to cow's milk, you can drink whatever. So based on whatever the concepts they have, parents or the children, they can have either cow's milk or powdered milk, either of them. Then when it comes to a child who is having cow's milk allergy, there are two things you can do, either take powdered milk or you can take fresh milk after boiling.
Yeah, thank you, sir. And there's another question by Dr. Hiranti Sandamali. So she has asked, need your opinion on recommending goat milk for less allergenicity. If I'm not mistaken, sir said that there is no such difference on molecular sizes.
Yeah, you are correct. You are correct. There's like no scientific evidence of goat milk being less allergenic than cow's milk. But sometimes parents themselves they select to go for goat milk and they come and tell me, this is my experience, but there's no scientific evidence. They come and tell me after shifting to goat milk, the wheezing or the skin condition became less, but there's no scientific, there are no trials done on.
Yeah, thank you, sir. And there's another question by Dr. Mati. What are the emergency treatment for severe allergic reactions? I think this will be important for doctors in day-to-day practice.
Yeah. So the most important drug is adrenaline. Adrenaline you give liberally. Don't worry about it. Nothing will happen if you give adrenaline. But if you don't give adrenaline to a child who is having severe allergic reaction, sometimes child or the patient can die. Then secondly, you can use steroids or antihistamines. But the problem is that in a severe allergic reaction, whether you give it IV or orally, it takes about 2 to 4 hours for the active action of the drug to happen. So adrenaline is the most important. Adrenaline and ABC management, IV access, and also monitoring are the most important things in managing severe allergic reactions. There is a general reluctance among doctors to use adrenaline, but adrenaline has to be used without fear because it's a life-saving drug.
Thank you, sir. And there's another question from Dr. Kalpana Hettiarachchi. How to identify food protein induced enterocolitis?
It's actually mainly by symptoms. As I told you earlier. So you have the enterocolitis syndrome where you can have even bloody diarrhea, gastrointestinal type of vomiting and diarrhea, steatory and all that. And you put the patient on an elimination diet. I told you how to do that, 4 weeks of elimination diet. So you can, if you are suspecting different types of allergies, you can't identify. So you can do one by one. For example, now you don't know whether the patient is allergic to eggs or milk. You say, so first you put the patient on milk exclusion diet for 2 weeks. Okay, there's no improvement. That means milk is not the culprit. You introduce milk again and you put the patient on egg exclusion diet. So likewise, one by one you can try, and probably after some time you will be able to identify the food which is causing allergy.
So there's another one. I think we answered this question from Dr. Mahir. Dr. Mahir has asked at what age cow's milk can be introduced to the child. I think that was discussed. And I think rather than a question, there's another question from Dr. Gamage. So if a child is having eczema already, but don't know whether it is provoked by milk, already undergone a adenoectomy at the age of 3 years, what is the prevalence of occurring of this? No asthma, but eczema still going on and taking milk further.
Now this type of child, now adenoidectomy, I don't think has a relationship to this particular patient. Now to diagnose eczema, if the patient is on antihistamines, you can't do the skin prick testing. You have to do the specific IgE test. So you can do a specific IgE test and see the cow's milk protein level in this particular child. So if the IgE levels are high, then you can arrive at a diagnosis of IgE-mediated cow's milk protein allergy. But if it is normal, still it can be non-IgE-mediated eczema due to cow's milk. So then there you can try the patch testing in this type of child. So patch testing could be tried in this particular type of child. The other thing you can do is put the child on a elimination diet for 2 to 4 weeks. Total elimination of cow's milk and see whether the symptoms improve. If the symptoms improve, then obviously the child had these symptoms due to cow's milk protein allergy.
I think, sir, rather than a question, there's a comment from Dr. Indika. So there was a history, some small child with a severe cow's milk allergy was given a cow in an empty milk packet by grandmother. And the child died after mixing small amount of milk powder with the cow. So he's telling people should be aware about this kind of
event. This is possible. This by exclusion is sometimes impossible. You can even small amount can cause a severe type of anaphylactic reaction.
Hope there aren't any further questions. So I will hand over the session to our colleague, Mr. Wabis, to do the closing remarks of the session. Wabis, over to you.